Thank you very much, Jonathan. It's a pleasure to be here to follow from the lab manager perspective how to improve the fruitful dialogue is here between virologists and clinicians. Here is just a slide that I prepared some time ago, but to say how was important the advent of molecular biology. We all have the experience that 2019 with COVID, in less than 3 weeks, the virologists were able to isolate the virus, to do the sequencing, and we have able to do the RT-PCR, the multiplex, to do the diagnostics. In 83, more or less, invented the PCR. In the 81, there was the first AIDS cases publications, and we needed more than 3 years, 4 years to have isolated the virus. And 55, in 85, the sequencing. So the advent of molecular biology was very important. Here we are speaking about drugs. So the big advent, thanks to the pharma company, to develop new drugs that before, unluckily, of course, we didn't have so potent. And we were using, and they were with low genetic barrier, so we have an increase of resistance. Even if the patient was high adherent, we have sequential monofunctional therapy, and so unluckily many individuals failed with multi-drug resistance. After we start to treat early with more potent drugs, with more genetic barrier, more tolerability, 1 pill per day, now we have a new strategy. So today we have much more less failures and less failures with resistance. But we need to remember, we still have, this is the last from the UNAIDS 2024, around 40 million of people living with HIV, 30 million are on treatment. So still we need to put a lot of individuals on treatment, unluckily still high number of deaths. And so we still need to work to find individuals and taking care and making to have an access to the treatment. And we know which is the goal of the treatment, to maintain the virological suppression and also to allow the people to eliminate HIV transmission, U equals U, and to have a normal life. This is just an example of our Italian court, Icona, to prove how in the previous years few people have HIV RNA below 50. Now, more than 93% have below 50, and 97% have less than 200 copies. So it's a big success. And I added the note, thank you for the collaboration with virologists and clinicians, because we know how to treat our persons that are infected. If the people fail, we know that fail with resistance. So this is just a slide to remember that all guidelines since many years say that we need to do resistance test in the person at the diagnosis and particularly at failure. Now I move a little bit about hepatitis C, because we have both this meeting take care also about hepatitis virus, and I was working a lot. I'm still working a lot with hepatitis C resistance. So just to remember that, and we will have later a session about hepatitis C. So hepatitis C still remains a pressing health priority worldwide. Now is estimated 1-3% of the global world prevalence, but still we have at least 50 million of people that are with chronic infection, and we have still 1 million of new infections. So this is very important everywhere. Also here, we have a big landscape of an evolution of treatment, big successful. And indeed, if before we were treating for many years people with interferon and ribavirin, now we have the new direct antiviral agents that allow us, to the majority of individuals, to achieve the virological suppression. But still, we should do, if possible, to do the genotyping, because the genotype can be important for guiding the success of the treatment. So the success of treatment, we know this is an old slide, but it's always to remember that if we want a successful treatment, we need to know who we want to treat and how we want to treat. So diagnostic tests must be very important. So regarding hepatitis C, we have a lot of factors that can contribute to the viral response. Of course, the person, if he's with the stage of the diseases, hepatocarcinoma, before we knew the IL-28, about the virus. As a virologist, we knew before that the genotype was very important. With some subtype 1A was very important, the resistant mutation ATK. After we knew about the genotype 3, now we have unusual subtypes. So from the virological point of view, also is important to take care. And of course, the therapy, the treatment. And we have a very good treatment. So this is just to show you how in the past, genotype 1 was the most difficult to treat with the peg interferon riba, and is still the most prevalent genotype. So this is the reason why the first treatment were all against genotype 1, but after now are pangenotypic. Anyway, few people are failing now, but before we were a lot of failings with this new treatment. And so, again, I'm working a lot with the clinician on that. And so we need always to think if there is an infection or is really a virological failure. And if the person fail, which could be the reason? And sometimes it's also wrong genotyping assignment. So we discover, at least in Italy, that many clinicians were treating individuals thinking, for instance, that the person was with genotype 1, 1A, 1B. So they treat with the treatment that is approved for genotype 1, but indeed they were infected with genotype 3. And this we discovered just doing the sequencing to do resistant test, and so we reassign genotyping. So thanks to the collaboration of virologists and clinicians, now in Italy we recommended to repeat before the treatment the genotyping and not be confident to the previous genotyping that was historical. This is a clinical case that I think was a big success for us in Tor Vergata in Polyclinic Hospital with an hepatologist. I was in holiday and he called me. I have a young individual that he started glecaprevir and pibrentasvir, and we were following the viral load. He saw an increase of viral load, say, what we do? And we agree to continue the treatment, to try to add ribavirin, and he asked to find sofosbuvir. Meanwhile, we did a resistant test at failure after a few weeks, and also at baseline, and we found out that indeed at baseline he has S5A mutation for glecaprevir, the 30K, and we decided to keep the treatment, and finally was cured. So this was really an intervention treatment that made a successful treatment. So regarding HIV, we know that many factors contribute to the long viral suppression. Here we need to treat forever. For hepatitis C, now we can treat for 8 weeks, 12 weeks, here forever. We need to remember durability. And so, of course, there is again the person, patients, and the convenience and tolerability, the CD4. And we know now how much is important the CD4, the nadir on the response. The drug, of course, drug levels and genetic barrier, and the virus. Virus, if there are subtypes, baseline mutation, and the burden. If it's high viral load, HIV RNA, and maybe also the HIV DNA. Here we are speaking, and this morning already we have discussed it before about the integrase inhibitors and the high genetic barrier. This is a very nice study that has been published recently by the group of Anne-Geneviève in France, where they saw that first line, second line success and failures, and according to the few failures, you see with Big Tough 6.8% failure, more than 2,000 individuals, and 4% of resistance on the denominator of the failure. Similar with dolutegravir and abacavir 30C, and dolutegravir 30C, first line or second line, and dolutegravir ripivirine in second line. If we go more here in detail, so you see large number of individuals, few failures, but when the people fail, the majority of the case, at first line, you don't see resistance mutation in the majority of the case, but you see more mutation on NRTI, on the companion drugs. And with dolutegravir and ripivirine, first line, second line, no dolutegravir mutation, but you see a lot of repeat mutation. And overall, 39% of individuals that fail with resistance. And also this morning it has been shown how the WHO now have making a warning that it is important to do the surveillance of resistance, because in several countries we start to see an increase of resistance to failure in people that are treated with dolutegravir. So the HIV scenario, I think, is evolving. So this slide from Aaron, I used it for many years when we were using to introduce the high treatment experience, the multi-resistance person, that luckily are few, but still we have. So on that time, on 2016, was a lecture of Joe Aaron. The majority of individuals were with virological suppression, but on that time, the majority, they have a lot of archive resistant mutation because they have a previous history of resistance. Few virological failure and the majority with resistance. Today we have few failures, some with resistance, many without resistance, and we have a lot of people with suppressed viremia. Many of them today, they don't have resistance, some they have resistance, and some of course have multi-resistance, so are the more difficult to be taken care. And so again, how is important the collaboration and the discussion between virologists and clinicians. I go very fast here, just you know the panel of the list of the mutation. So always when we are using new drugs, we know more information about resistance, and so we make an update. And so we have just make the update, and L74I, for instance, has been already discussed, that has been made as a major mutation. So just thanks to sharing with Milos his slide, I will focus a little bit about the low-level viremia and HIV DNA resistant test, because today is the majority of individuals have suppressed viral load, and so we can change, but we need really to think about the heart history, the whole viral load, and I think very important is the duration of the last virological suppression and the genotypic resistant history, and if possible, we could do the DNA resistant test, because can provide advantage, because particularly in people that have multiple virological failure or unavailable resistance history, or we will see also in low-level viremia at the time of switch. But the results still need to be taken cautiously, because we cannot detect all the mutation, or some mutations are not relevant because are ApoBec related. So it's very important the interpretation, and so far no guidelines recommend the use of the test, but many laboratories are using. Here is just to remember low-level viremia. We discussed it also yesterday on the poster tour. Many times we discussed that many individuals have low-level viremia, and so there is a worrying for the person and for the clinicians how to do. And we know that there is an extensive evidence that people with low-level viremia can have an increased risk of real virological failure. Definition of low-level viremia can be below 200, below 500, it's depending. And for the WHO, it's below 1,000 if we think about virological failure. So why we need to worry about low-level viremia? Because they can reflect ongoing viral replication, can be associated with the emergence of drug resistance, can follow it by high level of viremia, and may drive immune activation. But we need to divide the low-level viremia, the two scenarios. If it's the virus replicating, ongoing replicating, and can develop and have already, for instance, resistance due to suboptimal drug potency, or is just a virus release clonally by the expansion of cells, and the drugs are limiting the new infection. So it's just the virus release that is frequently defective. So it's very important to distinguish. So we can do resistant tests. Many people are doing, and this is our publication from 2014, to prove that the plasma HIV genotypic resistant test at low level is reliable and the resistance can be detected. You see, below 200, 52% of individuals have resistance. Below 500, 70%, and the success was very high. So moving to the archive, HIV DNA resistant test represent a new frontier, but we need to address the risk of overestimation, particularly for ApoBec and non-replicating HIV DNA, but also underestimation, because we took from PBMC, from full blood, so we cannot represent all the reservoir. And just to make, and after I think we will have the discussion about utilizing the proviral HIV DNA, we just did a very nice paper, I think, we discussed with me about discussing and how it's important and the limits and the possibility. I have the 2 minutes, about HIV, and probably also Maurizio will speak about this. HIV drug resistant testing. So, of course, I think the future could be the full genome. So we have thinking in many labs that we have before protease reverse transcriptase, integrase. Now we have the capsid, we have von Stemsa, virimalizumab. So many people are thinking to have a full genome sequencing for the drug resistance. There are 2 commercial assays. But also what is important, and we learned this morning also from Ravi, for instance, for the integrase inhibitors, but also with the protease inhibitors, we know that there are mutations, that are outside of the target region. And this normally is not only associated with resistance, but frequently can be associated with the increase of virological fitness. And how you can distinguish this, how you can identify? Normally with full genome sequencing. So this is probably the future to see individuals that have no resistance. And again, who have been at CROI, very interestingly from the group of Simonetti, he proved very sophisticated to isolate the RNA by plasma, single genome sequencing, that in people that have non-suppressive viremia, so they know that if you intensify, there is no decrease of viral load, the virus is defective, not only at the DNA level, already proved, but also circulating. So can be in some way a new way to see if a person has no suppressive viremia or is potentially evolution. So just a few slides to say how is important the collaboration between virologists and clinicians. So in Rome, in our hospital and with the university, with Anna Maria Geretti, we do twice per month routinely clinical case discussion. And once per month on CRCB with Carlo Federico Perno, with Bambin Gesù and other African people, they do discussion of clinical case. Once per month in Cameroon with all Viroforum Africa, 700 people we have in the WhatsApp. I did not make the pictures, but today, yes, we're finished. Yes, absolutely. Sure. So please. I go to the conclusion. Yeah. Sorry, I'm sorry, you agree. So I took the conclusion from Milos and I changed it a little bit or giving answers. So fruitful dialogue between virologists and clinicians, collaboration needed, absolutely yes. Subtyping as possibly important for some HIV therapeutic option, absolutely. And we can go to historical plasma genotype or do HIV DNA sequencing or in some way presume geographical origin as a proxy. HIV DNA genotyping test can be a very valuable tool for diagnostic of resistance. Low-level viremia, we should distinguish if it's early virological failure or non-suppressive viremia. And so we are working on that. And interpretation of susceptibility about new pathogens, cytomegalovirus in immunosuppressed, yes. And yesterday we have a beautiful discussion in front of the poster of Anna Maria Geretti about careful HBV reactivation when you are switching the treatment without not anymore HBV antiviral agents active. So thinking about the new drugs and the full genome. So this is just to thank you for how is important the collaboration. Here's the pictures of people from our lab, and below is the picture of last year of the European meeting and all the majority of the collaborators. Thank you, sorry.